Good morning, everyone. I know you're just getting in, so get comfortable, get ready. We have some great presentations for you this morning. All right, we're going to go ahead and get started because we have a lot of content to cover, and I know we all want to get into it. So, good morning again. We're here to do another 2 hours of CEs. Today's sessions are our final CE breakouts in conjunction with our 2026 NABIP Iowa Convention. One more huge shout out and thank you to our sponsors for allowing to put on a great conference and these fantastic CE follow-up courses. As a reminder, please keep yourself muted and video off during the presentation. That just reduces any distractions or echoes so that we can all focus in on the presentation. Keep an eye out on the chat because we will post a link in the chat that you must complete to receive your CE credits for this session. As I said, we will have two sessions this morning, and each one has been approved for one continuing ed or CE credit. You will need to sign in separately for each session. We will also be asking two polling questions during the program. You will see the first pop up about halfway through and the second near the end. If your organization's firewalls prevent you from seeing the form or completing the poll questions, please send your name and NPN number to the NABIP Iowa chat box.
There he is.
Oh, another great reason. If you can please all mute yourself. Thank you. We will have time for questions at the end, so please post them throughout the presentation and I will keep track of them. So, to start us off this morning, I'm excited to introduce our first presenter, Joe Garcia. Joe will be presenting Cancer Screening Initiative. Joe is the Vice President of Growth Strategy and Business Development for Aflac Worldwide Headquarters. Joe is a lifelong Iowan currently residing in Johnston. He is a senior insurance and financial services executive with extensive leadership experience across national organizations. Over the last 13 years at Aflac, he has been a territory leader managing a sales organization with more than 5,000 appointed agents and hundreds of brokers. His territories have generated over 250 million in sales annually, and he was recently promoted to a national sales strategy role. Prior to Aflac, Joe held senior leadership roles at Marsh & McLennan Companies, including managing director and chief sales and marketing officer. Earlier in his career, he served in executive marketing and product leadership roles at Guide One Insurance. Joe holds an MBA from Drake University, a BBA in finance from Iowa State University, and he's also active in civic leadership, serving on multiple nonprofit and corporate boards. Joe, you've been a busy person. All right. Thank you, Joe, for joining us this morning and sharing your insights. And just a reminder, everyone, please fill out the form that we drop in so you can get your CE credits. Joe, it's over to you.
Thank you, Allison. Great introduction. Thank you for that. Today's discussion is probably going to be a little different than what you may have seen for CE credits in the past, and I'll go over a little background. So today's discussion is going to be around an initiative in the state around cancer screening. Why it's important for insurance professionals is just to get an understanding of what cancer screening means and the impact that it can have in the state of Iowa. Earlier this year, I'll actually give a little more of a background. So as part of my role leading the territory, Illinois was included. And one of our largest clients to date is the Cook County in Illinois. So 5.2 million residents. And how we initiated this cancer screening program in Iowa, I got to know one of the commissioners in Cook County. His name was Bill Lowry. And Bill and I have become close friends. I meet with him again next year. He started an initiative in 2025, and it was all around screening for prostate and breast cancer. Bill is not a lifetime politician. He actually runs a 300-man law firm in Chicago. And he, after his second diagnosis of prostate cancer, he decided that he wanted to do something for the residents of Cook County, and he passed a resolution where they were providing free prostate and breast cancer screening for the uninsured in Cook County. And what they were able to do is any private or public hospital inside of Cook County, you're able to go in. You don't need proof of insurance. In fact, you don't even need proof of citizenship. You go in and you can get your PSA antigens tested. You can get a mammogram just by walking in. So again, this pilot program started 1/1/25. At the end of 2025, they reported a 17% increase in breast cancer screening in Cook County and a 14% increase in prostate cancer screening. One of the individuals who's involved in the cancer screening program with me is Dr. Deming, which is a name that's very familiar to lots of us. Dr. Deming convinced Cook County, in the state that he doesn't even reside in, to start including lung cancer screening, an LDCT test in Cook County beginning in 2026. And then next year, they will also include in 2027 cervical cancer. And we took that information and the success that he was having in Illinois, and we took his resolution, which was about 150 pages. My son, JT, goes to UNI. He's a senior at UNI. And he took that data and leveraged Grok, I think it was, one of the AI platforms, to make that data specific to Iowa. And he asked after populating all of this information about Iowa, what was the biggest thing that came out? And cancer screening came out as the number one priority. So you'll see in this presentation, we're talking about the benefits of cancer screening, early detection, and early treatment, and the significant positive outcomes from um, that screening, which includes saving lives, and you'll see saving money for the employers. So this isn't necessarily around cancer insurance, but we will get to how you can leverage some of this data in cancer insurance sales. So we'll get started here. We always start the discussions, and I should actually back up to, we have presented this information to 170 individuals across the state of Iowa, including our 2 US senators, all of our US House members. A shout out goes to Patrick Grassley, who really adopted and embraced this plan early on. It culminated in January. My son, myself, and a friend of ours, Mike Schreers, we were at the condition of the state address where they honored us in helping generating funding through the federal government. It resulted in 53 million a year for 5 years, so $250 million going to screening and early detection. The governor recognized us. She gave us a little more credit for what was happening and how it came about. But everyone on the line should know that the governor is behind screening and early detection. One thing that you should note too is that you're not going to see anything about root cause of cancer here, and the reason for it is highly politicized. And what we wanted to do is first get bipartisan support for cancer screening, and then this organization will go after root cause, but not until we move on cancer screening and early detection. And I think we've got a ton of momentum right now. We've got lots of companies behind us in the state of Iowa and lots of individuals. But when we start our discussions around cancer screening, we always state everyone has got a cancer story. So in the photo that you're seeing, my wife is in the middle of the 3 women. The woman to her right is Linda Schreers. Both we lost to pancreatic cancer in 2016 and 2017. You can see the big smiling face over their right shoulder or left on the screen, Dr. Deming. Dr. Deming happened to be my wife's physician. I was on the Mercy board at the time. Dick and I sat next to each other for 8 years. To give a little perspective on Dick, he made 20 house calls during the 10 months from her diagnosis until she died. I like to talk about Dick as the patron saint of cancer in the state of Iowa. He is on the board. We've created a 501c3, a nonprofit that is tackling cancer screening, and he is part of it and in constant discussions with us. So again, we talk about how cancer afflicts everyone across the state of Iowa. What we're talking about here is really putting screening and early detection in the forefront for everyone in the state. We like to talk about Richard Nixon. I know he's not the most popular president in US history, but on December 23rd, 1971, so it's coming up on 55 years ago, he declared a war on cancer. And he actually passed the National Cancer Act. If you look at the amount of funding that has gone into cancer research since 1971, in the US alone, we've spent $1 trillion with a T. Non-US spending has been around 1.5 trillion. So $2.5 trillion has gone into cancer research. And despite this level of spending, a late stage diagnosis is still life threatening. It doesn't mean that it's a death sentence, but it does mean that it is life threatening. The 5 year survival rate for the five main types of cancers that are screened is still less than 40%. So, despite spending $2.5 trillion, if you get a late stage diagnosis, you have a 60% chance of dying in 5 years. Some of those survival rates of late stage have improved very slightly over the time period. So you're going to see some data in these slides that are a little conflicting, and I want to address it. The reason they're conflicting, it's just based on the timeframes that you're looking at. So the data on this slide goes from 1974 to 85, and then 2011 to 2017, because they're looking at a multi-year period. After 2.5 trillion has been spent, lung cancer has improved. And I want to make a comment even before I go into lung cancer. There have been a ton of advancements in cancer research and cancer treatment. So there's been a lot of great work that's been done that many of you are aware, like immunotherapy is a great example in many different types of cancer. But still, a lung cancer diagnosis was 1%, a 1% 5 year survival rate back in the 70s. Today, it's an 8% survival rate, again, when diagnosed in stage 4. Colon cancer has not changed during that time frame, 14%, and it continues to be 14%. Breast cancer has improved from 19%, but it's still only a 29% survival rate in stage 4. Prostate cancer was at 30% and has increased to 32%, so a slight increase. What does that tell us? It tells us that we need to catch cancer early. We need to catch more cancers in stage 1 and in stage 2, where they can be successfully treated, and they can be not only treated, but there are a lot more options when you catch cancer early. The 5 year survival rate can move from as low as 9 or 10% for lung cancer up to 67% if caught in stage 1. Other cancers like colorectal cancer, 90%. Breast cancer has a 99% survival rate if caught in stage 1, and it's approaching 100%. Prostate cancer is a 100% survival rate if caught in stage 1. We like to talk about the return on investment is most important in lives saved and in families that are impacted. But there's also a major return on investment for cost avoidance by catching cancer early. And we'll look at some of those statistics today. If you look at where we are in the state of Iowa, and this is the reason why I wanted to bring what was going on in Illinois to Iowa. Iowa, we currently have, and I know this is in all over the media right now, the second highest rate of cancer per capita. The good news, if you can call it good news, is we do have the highest incidence of screenable cancers. So the 5 types of cancers that are screenable based on the USPSTF, the United States Preventative Services Task Force, are prostate, breast, colorectal, lung, and cervical. We are also the fastest growing state in cancer incidence. There are only 2 states that are growing, and Iowa is one of those 2, and we are growing the fastest at plus 0.6% per year. When you look at mortality rates, we're slightly below the national average, and rural Iowans face the highest mortality rates. And that has a lot to do with access to screening and access to care. If you look at physicians and nurses, the ratio of those individuals in the state, we ranked 37th in nurses per capita, 39th in oncologists per capita, and overall 44th in patient to physician ratios, which many healthcare publications have called a crisis. And in the bottom right, you see Cancer in Iowa. This is from the Iowa Medicine Journal. And in that journal, they've stated that cancer in Iowa is a public health emergency. So let's now compare that data. So second incidence rate, fastest growing. How are we doing in screening rankings? And this is from the American Hospital report that comes out annually. Breast cancer, we're ranked 18th in the country, prostate 25th, lung 23rd, colorectal 8th, cervical 15th. So when we put all of the data in for Iowa, comparing it to Illinois, and we're second highest, fastest growing, our screening rankings aren't keeping up. The numbers are important. Like many of you, I'm super competitive. I would like to see Iowa ranked #1 in the screenings that we have. But what's more important is what it means. Rhode Island, for example, is the #1 state in breast cancer screening. They screen about 78.8% of the females in that age range. The difference between where we are and where Rhode Island is would mean we would screen another 47,000 women for breast cancer a year. Simple math based on diagnosis rates, that means that we would catch 300 to 400 more women in earlier stages if we could get to that #1 ranking. Lung cancer would mean we would screen 20,000 more individuals for lung cancer. Lung cancer is the most lethal form of cancer in the state of Iowa. We'll talk about multi-cancer early detection MCEDs and that technology a little bit later. The 2 leading companies are Grail with their Gallery test and Abbott with their Cancer Guard product. And if you're a college basketball fan, you've probably seen a lot of the advertising for Abbott's Cancer Guard product. So what does the data reveal? It's simple. We've already talked about it. We're #2 in incidence rate. We're middle of the pack in screening. And so what came out of the analysis is that we owe it to Iowans to take the lead in cancer screening. Whatever that means for each form of cancer, we need to get out there. There are individuals that you are working alongside. There are individuals in the companies that we insure. There are individuals that are home with you that have cancer today that has not been detected. And by improving those cancer screening rates, we can have a significant and positive impact on cancer across the state. We can have a major impact on mortality rates. So screening saves lives and money. Prostate cancer, as I mentioned before, these are 5-year survival rates, and this is based upon National Cancer Institute information that gets updated every year. Prostate cancer caught in stage 1 has a 100% 5-year survival rate compared to a 37% if caught in stage 4. Breast cancer, 99% if caught in stage 1 versus 31% in stage 4. Colorectal is 90% versus 15. Lung cancer, 67% survival rate, and it drops all the way down to 10% if caught in stage 4. Cervical cancer is 90%, 20% if caught in stage 4. Cervical cancer is a little unique. We could potentially eradicate cervical cancer through HPV vaccinations, which are available for both males and females 100% paid for. And that's why Illinois is adding cervical cancer next year. There are two countries in the world that have eradicated cervical cancer through HPV vaccinations. And those HPV vaccinations have a major impact on many more types of cancer because the HPV virus can eradicate some of the other cancers or at least reduce them significantly. If we get to costs, this is the other area where there's a significant improvement in costs from treatment. Prostate cancer caught in stage one, and these are national numbers, not state numbers, is 50,000 versus 150 in stage four. Breast cancer, 60,000 versus 200,000 in stage four. Colorectal, 40,000 versus 115. Lung cancer, 125 versus 450. That's the biggest difference. $325,000 difference if caught in stage one versus stage four. Cervical cancer, 45,000 versus 175. We now came to the slide that will answer the question that just came up. If you take anything away from today, I want you to take away the knowledge of when screenings are recommended. And if Dr. Deming were sitting next to me, which he is in a number of these discussions, he was with me with the Iowa Business Council just 2 weeks ago, how he would start the discussion around the USPSTF guidelines and the recommendation on timing, he would say, work with your primary care provider. Your doctor is the best person to provide the direction because these are simple guidelines and this is what is approved and what directs insurance reimbursement. But you can get screened for cancer at different ages, again, based upon family history and genetics. So again, breast cancer, the USPSTF guidelines starts at age 40 and it goes to age 74, a mammogram every 2 years. If you have the BRCA gene, for example, in your family, if you have close relatives that have been diagnosed with breast cancer, your doctor can recommend that that screening starts earlier. Prostate cancer starts at age 55, goes to age 69. It includes a PSA test annually, which is a simple blood draw where they check your PSA antigens. The reason that it hasn't, it includes an informed conversation with your physician. 50% of men will have prostate cancer at some time in their life. And the informed conversation with your doctor, some forms of early prostate cancer, it may mean that you wait for a while before treatment. And so that's one of the unique ones that you see here, having the informed conversation with a physician in the USPSTF recommendations. Lung cancer starts at age 50 to age 80, and it's now a low dose CAT scan, which is a very simple procedure. And again, it's low dose, so limited radiation. In order for you to meet the guidelines and the recommendation, you have to have a 20 pack per year habit of smoking. And that is any time in the last 15 years. So again, 20 packs per year, anytime in the last 15 years, and you would qualify in the screening guidelines to get screened for lung cancer. Lung cancer has a stigma about it because a lot of folks don't want to admit to their primary care doc that they smoke. Lung cancer has also been correlated with radon, and we know the state has the highest level of radon in the country. And there's not a way to walk into a physician and say, I've gotten a radon test. The radon levels are out of sight or are really high. The guidelines still are based on smoking. What we hope is in the coming years that will change to include exposure to radon over a longer period of time. Cervical cancer starts at age 21 with a pap test every 3 years from ages of 21 to 29. and then it shifts to an HPV every 5 years. There's new technology that has come out on from an HPV perspective that allows for self-testing. That was just approved in 2025. So self-testing, like the FIT test for colorectal cancer, which is next, and it goes from ages 45 to 75. It's a stool-based test. Every 1 to 3 years, again, depending upon other questions that you would answer with your doctor, and then a colonoscopy every 10 years. So again, if you only take one thing away, take away the knowledge of when the USPSTF recommends that you get screened, but these are guidelines, and individuals' medical history and family history plays a major role here too. We know based on an AFLAC 2025 study, the top 3 reasons why people don't get screened. Number one is just awareness of the guidelines that we reviewed. Those guidelines do change over time. You can get to the guidelines on the American Cancer Association website. You can get there through the USPSTF. So it's important to continue contacting or going on and learning about any changes in screening guidelines. The ACA mandates cancer screening is free, no copay, no deductible. But again, it does depend on the health plan that you're on. So you need to understand your health plan and ask questions. So number one, again, is awareness. Number two is cost. The third reason people delay cancer screening is lack of access to healthcare or their PCP. And again, from a rural state, that makes it even more complicated. If you're a farmer in Green, Iowa, the closest place to get some of the testing would be Mason City, for example, and that could be an hour drive. But if we can eliminate these objections, we can drive cancer screening adoption and save lives. The future of screening. So MCEDs are multi-cancer early detection tests. These are tests that are done just by a simple blood draw. So you go in order to get this test, you've got to have a physician included in the mix, meaning you can't get the test without giving a doctor's contact information. The doctor isn't ordering the screening, but the doctor is involved. And the reason for it is that they don't want you to find out that you get diagnosed from cancer directly. They want medical intervention whenever that happens. So the MCED tests are not currently FDA approved, and there are costly. You can see here about $800 is the cost to get the Grail test done, and it tests for up to 50 different types of cancer. So the example of my wife was diagnosed with stage 4 pancreatic cancer. And oftentimes pancreatic cancer is diagnosed in late stages because you don't recognize that you have a problem until it's metastasized outside of the pancreas. And if you remember the 5 types of cancers that we screen: breast, prostate, colorectal, lung, and colorectal. They are tests that happen, and this should not be looked at as a substitute for, but a complement to those tests. But we can start detecting cancer like pancreatic cancer early. Dr. Deming has a patient in Iowa that used the Grail Gallery test a year and a half ago, was diagnosed with stage 1 pancreatic cancer. They were able to get a Whipple procedure, which takes part of your pancreas out. And now for like 500 days, this individual is cancer free. If you can afford this test, I would recommend that you do this independently. My guess is within the next 3 to 5 years, these tests will come down significantly in cost. It's currently cheaper than a mammogram. It's cheaper than a colonoscopy. But let's say 3 to 5 years from now, the cost gets down to 200 or 300. My guess is that you'll start seeing some overlap or even replacement of some of the other types of cancer. How it works is The tumors in your blood cancers throw off a DNA signal through proteins, and that's what they're picking up when they do the blood tests. Again, Grail is one example. Abbott has another example that they use called Cancer Guard. Both of them are very similar, and the efficacy rate of both is very close. But this is where we believe the future of cancer screening is going. I mentioned before Governor Reynolds' 53 million in cancer screening allocation that she got from the federal government. Those grants, the grants that are out there are starting to be used. They will include colorectal fit tests, colonoscopies, prostate cancer. They're equipping a number of rural hospitals with mammography equipment. So there's a ton of work that's going on behind the scenes in the state of Iowa. Cook County, we talked about. One important thing to note here about Cook County is that they did use something fairly unique, and that was they were communicating to residents of Cook County around their birth date. So they were using birth date as the reason why you would put cancer screening in front of an individual. In practice, what that means is when an individual turns 55 and you're male in Cook County, you'll get a reminder on your birthday to get screened for prostate cancer. Same with breast cancer at age 40. The initiative that we're moving forward with, and I'd like to mention Hy-Vee. Hy-Vee is our number one sponsor. They were the first sponsor that stepped up with a multi-million-dollar grant over 5 years. Our board chair was Donna Tweeten. And if you go back 2 months from now, we were celebrating the governor's grant and Hy-Vee's donation. And what ended up happening is Donna got diagnosed with stage 4 pancreatic cancer about 8 weeks ago. 20 days after her diagnosis, she passed away. So the new board chair will be Aaron Weiss from Hy-Vee, who's the president of their health company. And so Aaron is stepping in, and you'll see a lot more awareness coming out. So our plan will include a multimedia campaign using television, radio, outdoor, and PR work. So we will be videotaping segments with KCCI tomorrow, and there'll be a multi-segment focus on cancer screening that will go out on KCCI. We believe the other affiliates, the other channels will also come out with something similar, and that would be PR related work. We're working with major insurers and health systems and local doctors for promotion too. We're also promoting through pharmacies and retailers. Think about Hy-Vee, the number of individuals that get their prescriptions filled at Hy-Vee. We're going to use some of their communication, the text messages that say you have a prescription ready for whatever it is that you take. They're going to use that medium to go out and remind people of getting screened too. Faith communities have stepped up. We've had discussions with the Diocese of Des Moines, which includes 80 some churches, 16 to 18 schools. They will start sending reminders out to their employees, but also they're going to go out to their parishioners in bulletins. And we've got great support from churches across the state. We'll do social media posts. We hope that through Hy-Vee, we will get Caitlin Clark to be able to be our spokesperson. We'll hopefully have a commercial shot with her in the fall after the WNBA season. So you'll see a lot of that happening. We're also introducing in June and July an app focused on birthdays. So the nonprofit that we've created is creating an app that has two separate versions. One version of the app is going to be for consumers. That app will go out and it'll be made available to individuals in the state of Iowa, where you can log in and populate your friends and family or contacts. And on a permissions basis, right at the outset. So I'll go out, I'll go to my contacts, I'll identify my friends and family that I'm close enough that I know will be receptive of the messaging that comes out, and we'll send out a blanket message to all of them. Today, based upon your age, here are the USPSTF guidelines to get screened. And there will also be information on the closest place to get a mammography based upon your home address. In addition to that, we have an employer-based app, and the consumer app will be free of charge, available on the Apple App Store. Let's say July. It could be June, but we'll say in July, and it'll be under Cancer Screen Iowa. The employer also has the ability to download the app. There will be a very modest cost involved because of the setup. And by modest, I mean maybe a couple $100 annually, and potentially additional costs if they build an API to the app so that it connects directly to the HRIS system. So in the app that's available for employers, that app, how it would work is through the communication mechanism that they desire, like email. What they can do and what we're recommending is that they send out an email at the onset to all employees communicating the USPSTF guidelines, and they can opt out of this also. But then on their birthday, we will remind them of the screening. So there's an example in the top right of the screen. Justin, happy 55th birthday. We wanted to let you know that now, based on your birthday, that you've reached the age that the USPSTF recommends that you get screened for prostate cancer, colorectal cancer, lung cancer if you're a smoker, and give yourself a gift on your birthday of more birthdays and get screened. We have an example here that I'm going to try to play of a sample video or commercial that we've created that will not be branded. We'll see if we can get this to work.
Checkmate.
Check, please.
Hey, check that out!
Rain check.
The reminders are everywhere. Checkups and cancer screenings can save lives.
Checking in.
Check for cancer.
Okay, that's an example of a commercial that's been shot. Aflac actually created the video, the commercial. It has played in the state of Iowa. What we're doing through the 501c3 is we're making that available through PSAs or public service announcements that can go out. It can also be branded internally if you would want to play that at an employer to just remind folks about getting screened. So if you're out and you're selling to employer groups, for example, and you're really trying to get them to buy into cancer screening, we always start with the fact that it saves lives. We've talked about that before. It also builds culture and morale with your employees, knowing that their employer cares about them. There's a 2024 Gallup poll. It's a study that is available online that shows if employees feel their employer genuinely cares about them, they're 4 times as likely to be engaged at work, 53% less likely to be looking for another job, and 7 times as likely to recommend their employer. Profitability, again, we don't want to talk about that as being the number one reason why we do screening. But cancer, it's either, depending upon the study, it's either the number one, two, or three cost driver for healthcare costs. And that's based on a study done by the Business Group on Health. And again, you can find that online. It will positively impact medical trends, reducing medical costs for cancer by up to 3 times. It reduces medical inflation for the company and copays for the employees. The effort, again, it's inexpensive. It's almost free of charge. And by the way, you don't need an app. The employers can do these reminders. They can send out reminders at any time. Some HRIS systems like a Business Solver in Iowa, they have the ability to turn this communication on already. So it can be already there, just waiting for us to leverage. And we need to own the cancer narrative in the state for lots of reasons, including economic development. What company leaders can do is talk about the importance of cancer screening. What individuals can do, like you and I, is talk about cancer screening, make it not as scary for individuals. We should talk about it at the dinner table when you're together with friends and family during the holidays. You should take these guidelines and share them with everyone that you know and come into contact with in the state. You should evaluate cancer screening apps, like I said. Again, there's no HIPAA data here. We're just using name, birth date, and gender at birth to create the birthday campaign. You should decide if the MCED test is appropriate for you, your employees, your friends and family. You should evaluate incentive programs to get screened. Give your employees a reason to get screened. A lot of the cancer policies out there have wellness benefits that will actually pay individuals to get screened. And when these communications come out, like in the app at the employer level, we always say it's best to come from the most senior person in the company, like the president of the company or the CEO, because you know the biggest challenge in marketing is getting something opened and read. And when you get an email from the CEO of your company, it will always get opened and always get read. And then post frequent screening days, you can bring mobile mammography equipment or take blood draws at your employer. How we're going to determine success of what we're building is simply in the number of annual screenings. Again, the American Hospital Registry does screening studies every year. So that will be how we know we are getting better at cancer screening. We'll also look at the reach, how many people we know are seeing our messages. And then over time, a stage shift. So we'll see a larger portion of Iowans getting screened and getting diagnosed in stage 1, which will, simple math, increase survival rates over time in the state. And what we hope is that Iowa will become the state with the lowest cancer mortality rate. And through the bipartisan support that we've seen, we will hopefully take that and leverage that into getting bipartisan support for root cause. So I'm going to stop for a second and look at some of the questions that have come in. Yeah, I think there are a few of them around smoking and why that's the only reason that lung cancer screening that's the only variable in the equation based on the USPSTF guidelines. I would just tell you that we need lobbying at the state level and federal level to get radon to be part of that, and especially in the state of Iowa with being ranked number 1 in the amount of radon in our households across the state. When you look at for business, we are one example of a company that offers cancer insurance. So it's great that you do the screening, but people are going to get detected with cancer. And I would just say that the numbers are there and are easy to look at the justification by why you would purchase a cancer policy, 51% of employees don't have $1,000 out of pocket to spend if they do get diagnosed. 25%, so these are individuals that have been diagnosed with cancer. 25% have skipped or delayed care due to cost. 24% of cancer patients didn't fill a script due to cost. So having that backstop of cancer insurance that can come in the form of a cancer policy or a CI policy that includes cancer. Financial challenges. Individuals diagnosed with cancer have a 5 times higher likelihood of filing for bankruptcy. Credit scores are nearly 80 points lower after a cancer diagnosis because of all the costs that have been incurred. We've talked about employers and the benefit to employers. And then if you look at some of the other data that's here, direct medical costs, again, they're either the number 1, 2, or 3 driver of expense in health plans. 150 to 300,000 in first year late stage costs, depending upon the type of cancer. And even one case can trigger stop loss thresholds. Productivity impacts, we are showing that individuals diagnosed with cancer miss on average 60 plus days of work. Caregivers miss 20 to 30 days. And the average wage impact is 14,000 plus for an employee that makes around 60,000. So a huge percentage. And then just the volatility risk, high severity, low frequency claims. The wellness benefits that are included in a lot of cancer plans can make a difference because it gives an individual an incentive of 50, 75, $100 payment towards the wellness benefit. And remember, that wellness benefit goes back to the employee. So if they need that extra nudge, having that $100 to go out and get screened, in some cases where the employer pays for, there's no copay, there's no deductible, lots of times no office visit cost. So literally an employee can get paid to go and get a low dose CT scan, for example. Again, protects workforce stability. Individuals that are protected return to work sooner. They experience less turnover. And as we mentioned before, maintain higher engagement rates. Replacing one employee can cost 50 to 200% of their salary. And retention, as you all know, in a competitive work environment, really makes a difference. When we're talking to CFOs about cancer or a CI plan, we know the bottom line is that there's a benefit to the company. Again, reducing medical spend that can have a direct impact on the P&L of the employer. And oftentimes cancer or CI plans are voluntary, meaning the company is not paying for them, but the employee is. And we're starting to see a lot more companies contributing to both CI and cancer plans. And I'm going to wrap up and see if there are any additional questions. Allison, I can throw it back to you to see if there's any questions that came up that I might have missed.
I don't think so. This is such a great topic, and I'm sure I can speak for everyone on this call. Everyone has been touched by cancer in some way or another, whether it's themselves or someone in their family. I saw someone mention radon, and I heard you say that's going to take more work at the state and federal level. Any insight from you on where that is going, since I believe Iowa is number 1 for radon as well? Any
Yes,
screenings?
I would say, yeah, there are a lot of folks that are lobbying their legislators on radon and including radon testing, even if it's not USPSTF guidelines. We can have an impact here locally in Iowa. And so I would tell you, if you don't have radon mitigation in your home, that the tests are really cheap to get. So I would recommend ordering a kit online. You can order them from Amazon and maybe like $30. So as we're waiting for legislation to catch up, don't wait, act now, know what the radon levels are in your home, put a radon mitigation system in place if you do have high levels of radon, and then contact your local legislators. Start talking about how you believe that the state of Iowa, with our radon levels being number one in the country, we should find a way to get screened for lung cancer if you're exposed to high levels of radon. It can be that simple, a simple email to your local or our US representatives. And there's, I would tell you, a lot of traction, and there are a lot of folks that are out there doing the same.
That's awesome. I personally, we tested our house 4 years ago when we moved in, and levels were fine. And we just retested in February of this year, and we were 4 times the limit. So we just got our radon mitigation system put in. Best money I think I've spent in my whole life. So that's my personal shout out for anybody on this call that's like putting it off, putting it off. I worked with Iowa Radon, and it was awesome. So that's my little plug. But thank you so much, Joe. We really appreciate you coming in, sharing these insights, sharing your wisdom. We just really appreciate you coming in and presenting this CE. It does look like we have a couple minutes before we get started with the next one. So if you need to take a quick call or grab a snack, we will start here at the top of the hour. Hey, you've got water, you've got a snack. You're
Yeah,
good.
yeah.
Okay. Well, it is top of the hour, so we're going to go ahead and get started. So, welcome back, everyone. I hope you enjoyed those couple moments of free time. Just before we get started with our next speaker, I wanted to put in the quick reminder that you do need to complete the CE form in the chat. We will drop it here shortly. That is what ensures you get your credit for today's presentation. Again, this will be 1 CE credit. You will also see the 2 polling questions pop up during the program. If you have any problems interacting with them, answering them, or you cannot see them, please let us know and send your name and NPN privately to the NABIP Iowa chapter in the chat box. All right, our second speaker today, you've all heard me already talk to him, Tyler. Tyler will be presenting Fixing the Small Business Healthcare Crisis. Tyler is a health policy professional focused on expanding affordable coverage options for America's small businesses. As a native Floridian, he earned his bachelor's degree in political science from the University of South Florida before beginning his career on Capitol Hill in 2018. While working in Congress, he completed his Juris Master in Antonin Scalia Law School, deepening his expertise in public policy. He later transitioned off of Capitol Hill to the National Federation of Independent Business, NFIB, where he serves as the health policy lead, advocating for reforms that broaden access to coverage, eliminate burdensome Obamacare mandates, and push back against healthcare industry consolidation that drives up costs for small employers. Thank you so much for joining us today, Tyler. And again, everyone, please fill out your CEs. Tyler, I'll let you take it from here.
Yeah, so thank you for having me. It's always a pleasure to share NFIB's message for for one of our biggest issues, and that is healthcare. I'll give a little bit more background to NFIB in case anyone doesn't or hasn't heard of us or isn't aware of our advocacy. We're a trade association with 300,000 members nationwide. And we have representation in all 50 states. And then for my job specifically, I work on federal team, and we have a team of about 5 or 6 advocates that go to Capitol Hill every day and lobby for small business issues in Congress and in the administration. And so with that, I'll kind of just go through my slides here. And I'll be addressing the what I think is one of the biggest issues. Well, and it's backed by our research, but the fact that a lot of our members are struggling to afford their healthcare these days. Here's my contact information in case any of you want to reach out offline. I'd be more than happy to answer any questions you might have after this presentation's over. And so I want to make sure that you guys had my email. Um, so I'll get started here. Um, for the last 40 years, small businesses, NFIB members particularly, because this is our study, have come and or have taken a survey that's put out by our research center every 4 years, and they're asked, "What is your biggest problem?" When we get that survey back, the last 40 years since 1986, um, every single survey, the number one problem on that has said that the rising cost of healthcare was the number one issue. Um, we have, and we've come through consensus through our balloting measures with our members that small businesses want to see more affordable options, which could be accomplished by a number of ways. One of which is enacting legislation that, and I'll be frank here, that codifies rulemaking done in the first Trump administration that expanded a lot of options to small business owners that were then rolled back during either by a court or during the Biden administration, or just never codified by Congress, which would be nice. And I'll get into a lot of that a little bit later on. Um, Another way that we're looking at expanding options is through eliminating Obamacare mandates that have just simply gotten in the way. This, when we ask our members, what they think of Obamacare, it's usually not a very positive response. Usually, it's followed by that just an explanation of how burdensome the Affordable Care Act has been on their business. Um, and then a third way, and I'll address all these in greater detail, but combat we're starting to get into combating health industry consolidation. This has caught Congress by storm. Last week there was a Ways and Means Committee hearing that brought in five of the biggest hospital CEOs in the country. And they basically there was a lot of flaws uncovered, and lots of stuff that we're at NFIB looking into getting deeper into. And it might be stuff that I don't cover here just because I try to stick on the script of what we have backed by our members currently. But to say that the hearing last week opened some eyes is right on par. And I constantly, have to remind people why healthcare is the number one issue, and that's because of um, how it's a recruitment tool at its core, for businesses who are struggling to retain labor, and retain their workforce. You look at large businesses who are able to offer healthcare to their employees, 96% of whom are able to offer healthcare to their employees. Uh, and not surprisingly, we see that the ability to retain workforce, just like healthcare was the number one issue, workforce quality is right up there in the top five in that same survey. So I'll get a little bit into the numbers here. I know I mentioned 96% of large businesses on the last slide. So that's compared to 30% of small businesses. So you think about how big that disparity is. You have actually it's a little bit, the 2024 numbers are a little bit higher than 30%, but it's about 32%. And we haven't gotten the 2025 numbers yet, which will be released in July. But when you look at that big disparity between you have small businesses who only a third of whom can afford healthcare coverage for their employees. And then you have large businesses sitting almost at 100%, all the way up at 96%. It begs the question, what needs to happen to, or what get basically what gives? Why are small businesses not able to offer healthcare to their employees? Um, and I know a lot of time, and I've heard some really just heartbreaking stories from our members. There was I forgot the state, but I think it might have been Tennessee, somewhere in the southeastern part of the country. But we had a mom and pop shop. I think it might have been a restaurant. There, basically, it was yeah, a husband and wife running their operation, and the wife had to step away from running the business because they couldn't afford health care for their family. And so she had to go work for a larger company to be able to have the beneficiary on her plan rather than, stick with the family business. Yeah, that's that's just one example of the dire straits our members are getting into here with the rising cost of healthcare. Um, so you see some of these numbers here. I mentioned the 30% number you can see on that chart. But then if you look at, the 98% of small businesses that are concerned of their coverage in the next 5 years, it also begs the question, is the, yeah, it's 30% now, but it's set to get a lot worse if we're seeing that 98% of the businesses that are part of that 30% are set to, are afraid that they won't be able to offer health care. Um, and one thing that I guess could be attributed to this dip as well is the death spiral that the small group market is in. And you'll see in my next few slides coming up here that the small group market is very a lot of the reforms we're pushing is how to break out of the small group market and find something that's more affordable and flexible for the business owner. And so yeah, I'll start digging into a lot, and this is part one of our three-part pitch to reform healthcare, and that's what I call the expanding options pitch. Um, we're going to start with ICRA and individual coverage health reimbursement arrangement, which is on track, and hopefully this gets passed, but the acronym might be changed to choice in the near future, with this bill that's on the right panel here. If that gets passed, that would effectively change the acronym and a whole bunch of other things about ICRAs. Um, but yeah, basically the ICRA rule was an IRS rule from 2019 that allowed small business owners to be relatively hands off with health insurance. They wouldn't it it really is just a tax tool to provide employees with health insurance, but the business owner themselves does not carry the policy. Which when I say that to our members, they're very happy about because insurance can be a bear to understand in the first place. And they're much when I say there's a possible tax tool being worked out, they get a little excited over the fact that they wouldn't have to deal with an insurance company, and they would, there's a future that might exist where they can only provide the tax advantage dollars to their employees. Um, and so I'll kind of dive into the bill here. It's the Choice Arrangements Act. It's been introduced by Senator Sheehy and Rep Kevin Hern from Oklahoma. And so the changes that are made is that it one codifies the IRS rule from 2019, and then secondarily it would expand the what could be spent from those tax advantage dollars by the employee. Quite simply, it's a way for the business owner to fund the employee's individual marketplace insurance plan. And then on top of that, there's a tax credit that the government would provide to the business owner at $100 per month per employee for the first year, and then that would get cut in half in the second year that they offer an ICRA. I like to call this the win-win scenario of healthcare, because the business owner would have a budget-friendly option to offer their employees that they could live within their means and not have to go over and above to offer healthcare like they're seeing right now. And then on the employee side, the employee has the ability to design their own care model. You think, yeah, not only because of the changes to the current ICRA structure that this bill would or that this bill would accomplish. You have not only can they choose off the Obamacare marketplace, but they employee could also choose say they don't want a traditional insurance model at all. Say they want to spend this money on a direct primary care membership and maybe a short-term limited duration plan paired with that and they think that would be good coverage for them. That allows them the freedom and flexibility to do so, which should be should that's yeah it's gotten a little astray from this and on Capitol Hill certainly, but uh the goal of all healthcare should be to return power to the patient and let the patient be the driver of their healthcare. And then another way we're looking at expanding options is HSA expansion. This is very popular on Capitol Hill, mainly because HSAs are very popular themselves. I mean, you look especially towards the end of the year when I go past the Sunglass Hut and they're openly saying use your HSA/FSA dollars here. So HSAs publicly are very popular, which means that they're going to be very popular with members of Congress, and that's very welcoming to hear because healthcare reform on Capitol Hill is it's hit or miss sometimes. Um, and so ways that we're looking at HSAs to be expanded, especially through the lens of helping small businesses. One would be to enact the HSAs for All Act. That would decouple the current requirement of having a high deductible health plan with it, or basically, well, yeah, your high deductible health plan makes you eligible for an HSA. That would remove that requirement. So anyone with an insurance plan could then, whether it's high deductible or not, could then have an HSA. This I like to call it step one in President Trump's plan and his larger healthcare reform plan. As you may recall, he during last year's it, the premium tax credit subsidy battle, that Congress let the subsidies expire and hasn't renewed them yet. They basically, Trump said that we want, instead of this money going to the insurance companies as a subsidy, we want this money going into an HSA to be directly used by the patient. So this is something that we're hoping gets done and gets across the finish line so that more people could have access to HSAs instead of just folks that are on these high deductible plans with large out of pocket expenses already. And in some cases it makes more sense because you you would have more people it basically more people able to pay for healthcare, what say wellness plans or something that better benefits them. Instead, a lot of the times we see HSAs going or HSA dollars going straight towards a copay or something like that. Whereas now you can, if you don't have a high deductible plan or um, other out of pocket expenses that are extremely that you need an HSA to afford, quite frankly, you could apply that money elsewhere. Other issues that we're tracking in the HSA world are the ability to cover small group premiums. Um, that is a big push, especially from our membership. With our average member is a small business with 15 to 20 employees. So having an HSA cover small group premiums, which have gone up. I mean, some of our members flagged that they've gone up 30% or so over the or from last year to this year. And the way I see it is, if there's any way that we could that HSAs could go, even if it's say $50 a month, that's still chipping away at the say bring 30% down to 28%. At least you're getting going in the right direction. Um, and then we are also, and well, I think this is going to be a continuing battle, but increasing the contribution limit on an HSA is always going to be talked about in Congress, especially with inflation and how expensive services have gotten. We are, it'll never be a topic that's not talked about on Capitol Hill. Oh, wait, uh, oh, there we go. Um, so I'll get a little bit in talking about association health plans as well, which is another big push of ours. And we've been pushing for this ever since the court struck it down that you weren't able to have an association health plan unless you were in the same industry and geographic region. There's currently legislation, both House and Senate, by Senator Paul and Representative Wahlberg that would remove those barriers for entry. And our members love the idea of this because they see it as a way that your farmer in Iowa can partner with, or I don't want to use the term partner because it makes it sound like much more than just health insurance, but for health insurance purposes, your farmer in Iowa can join your barbershop in Florida in the same health insurance plan. And so, among them, they might only have 50 or so employees between the two. But if they join together with 10, 20, 30, yeah, the sky's the limit there as far as how many businesses they want to come under the same healthcare plan with. They would go from being that small group market, yeah, that typical small group health insurance plan to they'd now have the size and numbers to negotiate their rate like a large group plan. And yeah, when we're talking about easiest ways to drive healthcare costs down, it really is, if you have more beneficiaries, then you have a bigger pool, and lower, yeah, you can use that to your advantage and lower your rates. And so I mentioned the legislation, and it's been a little bit of a struggle, especially on the Senate side with Senator Murkowski and Senator Collins are a little bit uneasy about this. However, on the House side, it's already passed its markup in the committee. So we're hoping that, and on the House side too, it's bipartisan, as not only a whole bunch of Republican co-sponsors, as you would imagine, with Congressman Wahlberg being a Republican and chairman of the Education and Workforce Committee, but it has two Democrats, Henry Cuellar and Sanford Bishop, are also on they're on the AHP Act as well. And so another and this is the last expanding option item that I'll hit on today, but short-term limited duration plans is another option we like looking at, and mainly because these are plans that sit entirely out of Obamacare regulation, which makes their costs go way down because there's no mandates, and there's very little compliance with the ACA that has to be done. However, this has also been the biggest yo-yo by administrations where you've had a very restricted short-term limited duration plan period under the Obama administration. I think that was at 3 months, if I recall correctly. The first Trump administration expanded that out to 12 months of coverage with the ability to renew for up to 36 months. And then the Biden administration then rolled that back to 3 months again. So we're actively pushing for as long of a time period as possible, and there's been a lot of bills introduced on this particular issue in Congress. But when we looked at the Compete Act, which has been introduced by Representative Grothman and Senator Cruz, we thought that was a very good way to proceed with the short-term limited duration plan rule, because it would, one, codify that 12-month first Trump administration rule. I should note that the Trump administration, and it's one of our big asks with the administration right now, but they have not yet reinstated that 12 months. So currently it's at 3 months, since they haven't taken action since he's taken office last year. But we have currently, or with the Compete Act, we're pushing for 12 months of coverage with the option to renew into or I should say, a guarantee renewal with no additional underwriting taking place, into any health insurance or any short-term option that the insurance company might offer. And so that's very appealing to us because you could have a plan that's set out for 10 years that they can renew in, which that's 10 years of very low cost health insurance. We're all on board with that. And so I'll move now into the second part, or second chapter of our push for health reform, and that's ending certain Obamacare mandates that have just become super burdensome on our members. I'll start with what I think is the most egregious one, and that's the essential health benefits mandate. And so essential health benefits is a list of 10 services that an insurance plan with under 50 beneficiaries must cover. Um, I have a really good example of, I was on the phone with a member of ours that uh is a lawn care and lawn maintenance provider down in the southeast. And they were very frank. They said, we don't know why we have to cover maternity care when we hire all single male, and not on purpose, but just through the fact that it's a lawn care company and it's a very male dominated industry. They hired, so they didn't have any female workers, yet and all their men were single, so they didn't have any co-beneficiaries with them. And they were really upset with the fact that because of essential health benefits, they had to cover maternity coverage, as well as pediatric vision and dental, and the other mandated coverages that come with essential health benefits. And I note here in this sub bullet point, that we don't. It's not like NFIB is going out and saying, like, don't go see your dentist because that is an EHB. But we're saying that these should be just all a la carte offerings to a health plan per se. Basically, we're saying it shouldn't be something that's mandated by the government. And what we've seen is that it's ultimately pricing our members out of their insurance. We have members that can afford up to a certain amount. And then and that certain amount is still very valuable and really good insurance. But when they're asked to tag on these 10 mandated benefits, it that's when we really, it prices them completely out of insurance altogether. So they have to make the tough plan, like, do I pay the extra to have these benefits, or do I drop coverage altogether? And paying that extra would come at the expense of something else, whether it's cutting back on hours or, even laying someone off, or I heard someone even say that they couldn't offer their staff, their Christmas bonus that they've been offering for the last 50 years because they had to account for the rise in healthcare costs. And so there's been some good updates with this over the last few months. We've seen the I if I tried to remember the acronym for the rule, I would butcher it. So there was a CMS rule that came out that that eliminated, or it's a proposed rule right now. So if it was finalized, it would eliminate dental coverage as an essential health benefit, and it would also preempt federal law from enacting additional, or not preempt federal law, but it would require states to, if they had additional essential health benefits over top those 10 that are listed, they would be on the hook for paying for those benefits. So that really douses water on states enacting more essential health benefits, especially, and we don't think any, the more conservative states wouldn't do that, but you would see that a lot in the Northeast, and certain states on the left coast. So we're very happy with some of the outcomes that could come from that rulemaking. We're just hoping it gets finalized as is. Another issue that we talk about a lot is medical loss ratio and the mandates that come. Um, yeah, and it mandates that 80% of medical spending by insurance companies is actual medical care, whereas the remaining 20% can only be kept for administrative costs and profit. The problem with that is the fact that you run into the mathematical problem where 20% is the basically you have it that gives insurance incentive to, and not only insurance but also PBM's incentive to charge more for services, because the higher the price, if it's a percentage, 20% of 100 is 20, but 20% of 1,000 is 200. Or sorry, I'm not even gonna try math. But I'll I'll leave it there. Actually, I think my math was right. I apologize. It's been quite the week. Um, and so we're and an interesting part. I mentioned PBMs, but part of um part of PBM services actually go towards the like I have said here, the 20% that goes towards the administrative costs and not towards the medical care. So that's another, sort of mathematical problem that we're seeing that MLR causes. And we're looking to reform that. Whether some folks have proposed eliminating MLR and letting free market principles take over. Some have proposed shifting PBM services to the medical care side of MLR instead of the administrative side. We haven't taken a stance one way or another. We're just monitoring to see what options certain members of Congress come up with, and and picking what we think would be the best one when they're all laid out on the table. And then community rating is real simple. It might seem a little bit complex, but basically it's giving it, right now we have an unrealistic snapshot of the reality of who's covered under health insurance. And the 3-to-1 ratio with community rating makes healthcare costs for younger individuals much more expensive. And these are younger individuals that are in the workforce. And so that would drive up costs for business owners. And so we like proposals that are out there to broaden it to a 5-to-1 ratio. And then the last thing that is something that we also support is eliminating the PCORI fee. And this it's a $4 per beneficiary fee that gets basically put on business owners um, for funding for research into effectiveness of certain drugs. Um, and this, if you're looking for any way to cut spending, this is one way. You say, if you told a business owner you get to save $4 per employee that's taking you up for your health care immediately, that would be very enticing. And we'd be in favor of eliminating it entirely. And so the last part I'll get into here is health industry consolidation. And we feel that I have it here in the subtitle, but the markets that have condensed are just destroying competition. At NFIB, we have several independent physicians that are scared to death of being bought out, of having no other choice but being bought out by a bigger hospital system. I kind of go into the numbers here a little bit, and you see, I have listed here, and it's one of the scarier numbers out there today, but 9 out of every $10 goes through a third party. And yeah, more, when you look at the numbers even more, this gets back into PBMs, but three PBMs dominate, 80% of the market, and over 70% of hospitals are now part of a larger hospital system. Which the hospitals are, it's an interesting trend how fast they've consolidated. Um, and obviously they're destroying market power and they're the ones that are now dictating the prices. So continuing on with hospitals, but there's some reform we're looking at. And one of the more bipartisan measures in Congress for all health, for all of health reform is hospital price transparency. And the way I see that is that as Americans, we're so far removed from being a consumer of our own healthcare that, you could, it's shopping for healthcare services. Like, say you need a hip replacement, knee replacement. It's not as easy and not even close to being as transparent as going to the grocery store. I know it's an interesting analogy, but you can go to the grocery store and say you're looking for rice cereal, and you could shop. There's Kellogg's Post, the store brand, and you can compare prices for all of those. And we're the Patients Deserve Price Tags Act that's listed down here, that's been introduced by Senator Marshall and Congressman James. We're very hopeful that this gets enacted, mainly because it provides consumers, or patients in this case, with both a menu and the receipts. So the menu part is, I laid that out. You would be able to look at other, not only hospitals, but outpatient facilities, and really just shop around for the best and most affordable price the same, for the same service, essentially. And then so that's the first part of the bill. The second part, where I talk about receipts, is that you see afterwards what the hospital is actually billing back to the insurance company, which really helps with, when, you could self audit your insurance and make sure that you're not, that, the hospital isn't, excessively billing your health insurance, which, there's been several cases of that where, doctors are billing, just ridiculous amounts of dollars to the insurance, and the insurance is paying for it, causing premiums to spike. We're also looking at site neutral policies. And this is, we've seen it a lot with the expansion of hospitals taking over outpatient facilities. And so, as an independent outpatient facility, they were able to offer a much, or they would be reimbursed a much lower rate. But and once the hospital took them over, their reimbursement went, well, they got the hospital rate for reimbursement, which we just want to see that be brought to neutral instead of the hospitals getting a leg up when just because they take over an independent, and same everything about the facility except for now it's a hospital-owned facility. And then the last thing I'll cover is PBMs. And so we did get some good wins with PBMs earlier this year. The Consolidated Appropriations Act, um, sorry, taking a sip of water here. So the Consolidated Appropriations Act included a bunch of PBM transparency requirements. This is basically peeling back the onion to the the rebates the PBMs get, the how much they're actually paying the manufacturers for drugs. The list goes on pretty extensively. But there's still a lot of actionable items that are desired. I say actionable because uh, with I just think of the typical NFIB member and what they would have on a day or what they have going on a daily basis. And as great as transparency is, the action needs to come from a ban on spread pricing, where yeah, the if the PBM is getting a rebate, that rebate is definitely going to the consumer and not getting pocketed by the PBM for profit. I'll go back. I know I left the thought unfinished there, but with our members, because they're running a business every day and their lives are very hectic to begin with. I just, as great as some transparency requirements are, we're pushing for more just because and I've seen some of these government documents, they're sometimes 500 pages long. So to expect someone that's already running a business to have to filter through 500 pages of documents of transparency from PBM transparency documents, we want a little bit more added on top of that. And so that's the last slide I have, and I'd be more than happy to take some questions.
Hey, Tyler, it doesn't look like we have many questions. Friendly reminder to those, if you have a question, please drop it in the chat. Oh, Marcy just came off mute, so I think maybe she has a question.
Well, I just kind of want to go through some of this because, when we look at all these things, a lot of us are managing group benefits for employers. And so I just want to remind you guys that NFIB really is a small group, small employer association or federation. And so if you're not a part of NFIB, you probably should look into doing that. But then also, this is something that as you're working with other employer groups, that you should probably consider sharing with them as well. The amount of work that they do on the national level is pretty insane. I've had an opportunity to testify in Congress multiple times through the NFIB team. And so our voice can be very loud, and they pay attention because unfortunately on NABIP, when we go, we don't get as many opportunities because we're looked at as insurance agents. And I can go and actually testify on behalf of employers. I am a small employer myself, but my clients are all mostly small employers. And so it's just a different perspective. Unfortunately, it's politics, right? Because we are the experts, so we've got a lot of knowledge. I just use a different avenue to get in there and help to influence that. But you'll see, most of these things are things that we are aligned on and want to make sure that we're supporting. So again, when we work with other groups like NAFA, the bigger our voice can be, the better. And so I think just as always a reminder is to just have conversations and be talking about these things, not only with your actual clients so that you can help them to better understand it, but go out and have coffee with your legislators in your area. And you can even go down to city council and different smaller opportunities. So again, I'm so thankful to have Tyler here representing NFIB today, but we all kind of have a role to play in this as well. So just kind of putting that out there. That's it. That's all I wanted to say. I don't know. I didn't see any other questions either. I was just dropping comments in just to kind of connect people to some of the NABIP stuff that we're working on. But otherwise, it's
No, and I appreciate the comments and yeah, the when we think about connecting with, especially because I know when you testified, Marcy, you testified with Senate Health Committee the last time you were up here, and they just did a part two to that hearing or Tuesday. Sorry, the week's just it feels like just flying by, but they Tuesday they held a field hearing in Chairman Cassidy's home state of Louisiana. And that's where whereas I thought the first hearing went very well with hitting the mark on a lot of these important issues. The second one, they did a lot of beating around the bush, and we're always happy to find folks that want to dive deeper than just beating around the bush to some issues.
Yeah.
And a lot of it is rooted in I mean, if you go back to, it would take me forever to get back to that first slide, but the decline in small business offer rate, you could really see how it dips in 2010, which would mean right after Obamacare, yet the the appetite for making reforms to the actual ACA is very little, as opposed to a lot of folks today just want to throw money at a problem.
Yeah.
And that, as great as that can be, or as that good as that might sound, just getting money thrown places, sometimes you got to address the root of the problem to solve it.
Yeah. Do you feel like now we actually have the attention? Because it feels like for a lot of years we were coming and having conversations and talking about these challenges, but now I actually feel like even, last year it started where they're paying attention, like they're really trying to get to the root cause of these issues, which is why we're seeing so many more hearings.
Yeah, and so I think part of it, I think they're getting there. It's just how much time they're afforded. Obviously, politics are working on a 2-year clock, and we're 6 months away from the end of that 2 years, where hopefully, yeah, I like to say I'm hopeful that any Congress would prioritize proper healthcare reform, but the sides are so split right now that we're hoping that there are, and especially from our perspective, that we get lucky with several small business advocates being placed in in these positions in Congress, especially with the amount of open seats this year.
Yeah. Yeah,
Um,
and that's the other thing too. Yeah, getting people to step up to the plate. You would never catch me. I will not be running for any sort of office. I don't care if it's school board or what. No way. I like being on the outside, but we do have to rely and NFIB again has been, really successful in getting small business owners into some of these positions so that they can be a voice. So again, I appreciate everything that NFIB is doing, especially, for those of us that are working in the group market, and our clients really need this support as well. And you guys do such a great job of surveying and communicating and getting information out. So again, that's just my plug, for NFIB. If you guys have not taken a real look at this, I would consider it. They actually have their day on the Hill coming up the first week of June, which I am feeling major FOMO to miss out on. Um, this year I will not be able to attend, but it is really an amazing experience. NFIB does such a great job, and you do actually get in there and meet with your legislators. So if that's something that you guys are interested in, it's very affordable, and a really amazing experience. So again, I would just encourage you guys to look at NFIB as an option for your business as well as some of your clients.
Definitely. I mean, I can't say it any better. I will say, and I don't, Teresa, I don't know if I need to send this to you, but we have our legislative health care plan that we put out a couple months ago. That's much more, it's much more digestible of a read than the PowerPoint slides, and I'd love to have that distributed to the group afterwards.
Yeah, yeah, send it over and to either Marcy or myself, and we'll make sure it gets distributed. Also, if we can share, if you don't mind if we share your slides, send
Yeah,
those and we can distribute those also.
definitely. I can package those up and get them over to you.
Great.
Well, thank you, everyone. Thank you, Marcy and Tyler, for the great conversation here at the end. Uh, That wraps up our CE sessions that were with the Iowa NABIP convention. Again, thank you to our sponsors and presenters and everyone that took part in this. We could not have made this without you. Please join us again on June 17th. Start that again. Please join us again on June 17th for more CE presentations. We have some really great ones planned for the summer.